Anim, bonjour. Hello, everyone. Welcome to today's virtual peer sharing and learning session. Today, we're going to continue to focus on optimizing team-based primary care and talk about building primary care teams through discussing approaches that leaders can leverage to create teamness. And we'll talk a little bit more about what teamness means. So we're going to give everyone a few minutes to sign in before we start. As we wait, please introduce yourself, your organization, your OHT or PCN in the chat box, and just make sure you select everyone so that we can all see who's joining. By now, I've had the opportunity to meet most of you, but for those of you I have not met yet, my name's Leslie McGeough, and I am a coach and focal point with RISE, supporting population health management and primary care. Thanks for joining us today. I'm also just going to bring up on slide here, and Steve's going to share it in the chat box. For people who might be new, we do have an OHT shared space dedicated to this primary care work where you can watch previous sessions. You can access other resources such as briefs, which we post here. And you can also post questions to your peers between sessions as we monitor the chat that is posted in this online space as well. All right, thank you all for joining us. We've got Jamie Lynn, Kate, good to see you here from Chatham, Kent. Please continue to introduce yourselves, but we are going to kick off this session. I'm going to pass it over to my colleague at RISE, Jin Fan, who's going to walk us through today's land acknowledgement, but please continue to introduce yourselves in the chat.
Yes, I'm ready, Leslie. Hello everyone, thank you all so much for joining with us at this time. I'm very honored to acknowledge that my home in Toronto is located on the traditional territory of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Huron-Wendat people. And Toronto is covered by Treaty 13. I also acknowledge that my place of work, Northam University, respectfully recognizes that our Pan-Northern campus is on the homeland of First Nations and Métis people. The university buildings on the Greater Sudbury and Thunder Bay are located on the territory of the Anishinaabe Nation, specifically Anti-Convention Anishinaabe, Wanapati First Nation, and Fort William First Nation. As someone from Asian ancestry background and a young scholar working in the healthcare system, I'm very grateful to live and learn on these lands. I recognize that being a guest here, I carry a responsibility to approach my work with respect, humility, and ongoing commitment to the truth and reconciliation efforts, which including listening, learning, and supporting Indigenous health, sovereignty, and self-determined priorities in meaningful and accountable ways. Thank you, Leslie.
Thank you, Jin Fan. Right, Mike, I'm going to pass it over to you to kick off our session.
Okay, welcome everyone. Thanks for making time to come and attend. Before I get started, just want to do a shout out to Parry Sound, whose Megan Oldman won a gold medal in I think it was the ski big air. So congratulations, Parry Sound. Today's agenda, we're going to do, it's about gaining an understanding of primary drivers for building primary care teams. It's a recap of some of the core concepts that we've talked about. And we're going to look at creating teamness and learn from some of the other teams about what does teamness actually mean and how does it help deliver care. And then we'll finish with a group discussion as we usually do for questions for the presenters or other questions that you might have. And the objectives for today are to understand the approaches for leaders to create teamness, because you've got to have good leadership in order to build good teams. We'll learn from examples of creating functional teams through their team structure, how they communicate and process changes that they've made, understand the barriers and facilities to enabling team-based care, and then continue to exchange learnings as we do in these sessions by having the audience talk about the work that they're doing also. So this is our mandatory slide that we always start with. It's the holy grail of what we're trying to do, going from the chaos on the left to the high-performing accountable care organization with primary care at the center. Most of you should be building this model on the right in your mashed potatoes at dinner. And I would like anyone that gets that reference to type it into the chat box. We'll see if we have a winner. Go to the next slide. Again, want to remind you that this is work that, while it may not show up in your TPA specifically under building high-performing primary care teams, what this will do is help you with your TPA requirements, such as developing community-based plans for chronic disease prevention and management, ALC action plans, increasing participation in cancer screening, expand access to online appointment bookings, facilitate adoption and report on progress for e-referral solutions, and curate information about local services. So this work is tied together, and it will be the work that you'll be looking at as we go forward in the following years. Well, I don't see a winner yet on who got the mashed potato reference. I'll come back to it. Recall once again. Yes, Dean, we've got a winner. Close Encounters of the Third Kind with Richard Dreyfuss. Recall that when we talk about primary care teams, many people can make up the team, and they don't all have to be in the same space. They don't have to be all co-located, but they can be shared across teams. But I think the important takeaway from this slide is that the team is not necessarily just the clinician and a front office and a nurse. There's many more people that can be part of the team to make the team more efficient and deliver not only population-based care, but more effective care that impacts the quadruple or quintuple aim. Next slide. So we've heard, what's in it for us? You're now asking us to build high-performing care teams. We've got lots of work to do in the OHTs and the PCNs. But I think, what we hear from clinicians, and specifically primary care providers, is that when they work as a team, there's a number of things that happen. First of all, they reduce ER visits and hospitalizations. That's well documented in the literature, and of course is a prime directive of the Ministry of Health. Helps them deliver proactive population-based care, so they're able to look at groups of people and deliver care proactively rather than reacting to them coming in the front door and not necessarily being prepared for them. Provide timely access and increase capacity, so teams that function efficiently create more appointment slots for people to come in and not just necessarily visits, but e-visits or visits with the nurse, so on and so forth. They share the workload and streamline workflow, so it reduces burnout in teams. It improves patient trust. That is, patients sense that they're being cared for by a team and are more trusting of the medical care that they're getting. Again, in the literature, it increases safety. There's less medical errors. And then some personal notations that I've heard from primary care providers is that they get to go home on time more often. They're not in the office until 8 o'clock at night, catching up on administrative work. They experience higher levels of joy at work. They feel like they're making a difference in their patient's life, and all the team members feel valued by their colleagues. So there is a lot in it for the teams to be, the primary care practices to be working on team-based care, and for the OHTs and PCNs that are part of this call, this is a big chunk of where you can dedicate some energy to help the primary care teams achieve a level of teamness. I'll pass it over to my colleague, Rob Reed. Rob Reed is a co-lead at RISE and has been a colleague for many years. We worked together in the US, and he is, well, I guess you've retired from Trillium, but he was in charge of the Health Sciences Research Center at Trillium, and he is the person you go to when you want to know about building team-based care.
Yeah, and thanks, Mike. And so nice to see everybody today, and welcome to another RISE event. And hopefully we're meeting your needs. I'm going to go very quickly about, teams just don't happen. Teams are built. And what does it really mean to be part of a team? And dig into this a bit, because it really provides directions for leaders in primary care as how you create teamness among all of those individuals, often in different practices that Mike was talking about. So their teams are composed of more than just individuals. They're people working together with complementary skills collectively to the same goals. They're built always on foundations of trust and mutual respect. So each team member respects the work that the other team members do, even though it's different. Effective primary care teams are highly relational. These team members have to interrelate and they're highly interdependent. They depend on each other to get the work done. And to do that, team members develop shared knowledge about what each other's does, each other's roles and responsibilities. But they often role blend, right? So if you're a defenseman, sometimes you have to come up and actually act as a forward. And so often that they will take on tasks for other people to gain efficiencies and synergies. And this happens all the time in primary care teams. For teams to really function, communication is important. And research suggests that it's frequent, timely, accurate, and problem-solving communication. So leaders are responsible for building those communication channels and having them used for their team members. There is a lot of research about teamness out there right now, and one can think of this as relational coordination. Effective teamness is about effective communication that facilitates effective relationships and vice versa. And there's a reference there if you'd want more information on it. So the next slide very quickly now is what do leaders then need to do? And you're going to hear real examples in the next three speakers of really these leaders and their experiences in leading for teamwork. So remember, teams don't just happen. They build and nurtured over time, and it's the responsibility of leaders and managers and coaches to help teams build and nurture their teamness. There's a variety of key structures that are essential for leaders to put into place that help with teamness, particularly shared protocols, directives, standard work templates that help each other understand, all the team members understand the tasks and responsibilities for all the other people. Shared meetings, huddles, and opportunities to reflect, learn, and plan are about communication, as are shared information systems. But leaders have to do more than that. They actually have to really select and train for teamwork. In healthcare, unfortunately, we train often for very individually. We do things ourselves. It's very isolated, and this is a different type of work because you're interdependent, and so training around those interdependencies. Develop shared accountabilities and shared performance metrics. How do you know teams are working? What's the measures of teamness that you can actually build performance metrics on? Shared accountabilities, shared recognitions, and rewards. There's real evidence about the importance of this. Teams often get into trouble with conflicts, and their leaders have to have reliable mechanisms to resolve those conflicts. And there's a lot of research around different ways of doing that. We often now have to design our roles with teams in mind, and actually have people that can blend very quickly between different roles. So those boundary spanning roles. And then finally, a real work on work for teams to help solve problems together and building some momentum. So there's the research evidence on how you build teams. Now we're going to hand it over to the next three presenters to really talk like what they've done to do this. And the first, I'm going to hand it over to Dr. Dean Roll. Dean is a clinician, as Mike was saying, worked for many years in teams, and he's going to talk a little bit about what his experiences were working in highly functional teams and what leaders did to help those teams function well. Dean?
Great. Thank you so much, Robert. Actually, this is so exciting today to talk about the experience I had with the development of healthcare teams working in the United States and Canada. I was part of an organization of about 1,200 providers that worked during the time that they developed the patient-centered medical home and team-based care. It's very cool now, again, as we're doing this in Ontario, and that big paradigm shift of moving from individual practitioners to teams with multiple professionals, RNs, MOAs, mental health, MDs, nurse practitioners, all sorts. Teams are whoever you need to provide the best, most appropriate, necessary care for the population. When the organization started the use of a team-based care model, leadership initially assembled the people, divided everyone into smaller manageable teams, geographically, sometimes separated, sometimes together. I was initially in a small clinic of basically just two providers, so we were combined with another clinic with some geographical proximity. Last month, we had talked about teams typically of about 5 to 7 physicians and nurse practitioners with MOAs, mental health workers, RNs, RPNs, as a manageable size for the group. People were definitely selected and trained for their teamwork. After sort of putting the people together, the vision and core values of the group really needed to be sort of manifested and sort of delineated for everyone to understand. And again, from the leadership to the team members, sort of to get on a same idea. Some rules were set when we did this. There was sort of this standard work, the tight work that's been described previously, was expected of all team members based on their very defined roles, which we've talked about with scope of practice, and making sure that all members of the team knew both what they were expected as well as everyone else's roles to complete tasks. Shared awareness and understanding and respect of all these different roles and the role-specific competence to perform both clinical and non-clinical tasks within the team, and even sometimes to understand the individual's capacity and adaptive abilities within a role. Psychological safety within the team and for all members to be able to feel free to contribute and to try to reduce the power differential within team solving was very paramount in this as well. And an expectation to share the tasks to get today's work done today. This included sort of both the scheduled or planned care as well as opportunistic care for patients. As we had talked before, is everyone is providing comprehensive care for a patient. So again, sort of a physical therapist seeing a patient, noticing a vaccine was needed, would get the patient over to the clinical team otherwise to get that vaccine done today rather than scheduled for later. We started with actually some sometimes very light activities, including games for the teams. We had icebreakers at meetings to sort of better understand each other. I looked online and even things like escape rooms or bake-offs, potlucks, and that to understand and learn more about individuals' problem-solving skills, about their personality, about team dynamics, responsiveness to change, and to understand the people you work with, not just the roles that they're working. And identifying and nurturing leadership was crucial during this time. It started with our leaders, or to kind of use self-serving terms here, are the coaches. But as sort of you start the activities, you start to see who was more adept in teamwork and who could be utilized in that role to help bring others along and helping along there. The team in action, I'll sort of say 99% is communication, both sort of for the teamwork as well as the task work. We're still providing healthcare, but while we are building our teams and making sure that the tasks are done by those to the top or breadth of their scope and skills. As discussed before, and many more times for sure, daily huddles, 5 to 10 minutes every day at the start of the day, review the daily functions, course correct on small issues, dissemination of larger concerns to the clinical unit. Is vital and again gets everybody up to speed and ready to go. Meetings of the team leaders, bringing sort of issues up in levels if they were bigger, affecting more people, or needed larger solutions for things like space, resources, money, manpower resources. These were less frequent, but the leadership of small 5 to 7 people teams could definitely be sort of brought together very quickly, and make course corrections as needed. And then we also had collective meetings of multiple teams and all team members. Again, just sort of getting everybody together, making sure people are all on the same page and moving forward. The team in evaluation was kind of what I talked about as well, and Dr. Reed had mentioned as well. Setting accountability metrics for the teams, both in terms of patient access, patient satisfaction, patient quality, but also things like team member satisfaction. Our organization used annual evaluations that I would complete for my team members, they would complete for me, and that was how I sort of saw and learned how I was working both with the team as well as for my patients. Um, it was important as well to celebrate success. Both for the teams and the teamwork, as well as for the patient care and the task work of the team, and as well to recognize challenges. We would share rewards and kind of look for ways always to improve. I still kind of remember a 5-to-1 rule of making sure compliments and praise is given at least 5 times for every time you need to add something to course correct. Creating a reliable way to resolve conflicts. Again, no team will be perfect forever. Again, from 20 years ago, I still remember the term courageous conversations and still use it in my daily life. Having those courageous conversations to get across things when it might be difficult and uncomfortable, but in an open, authentic, and honest way. And kind of as well, teams are going to change over time, both in what they need as well as in their membership, and developing ways to adapt is crucial for this. I didn't use any hockey analogies in this, as Rob had previously done, but that slide, I guess, kind of teamwork successful is that feeling that we're just hoping will be coming very soon to all of Canada. So thanks so much. And we look forward to more questions.
Thanks so much, Dean. We're going to hear from Melissa Harvey, who is the Executive Director at the Nipigon District Family Health Team, which is in the Nujma wing. I forget the second part, Melissa, but it's in the Thunder Bay District. Just before Melissa starts, Nicole, you have a fantastic question in the chat there. When we're finished with the presentations, I'd like you to bring that question up, because I think it's one that all the teams will be struggling with. Go ahead, Melissa.
Thank you. So I am here just to kind of give some granular day-to-day examples of like what we're doing here to improve our primary care team. So essentially here in Nipigon, our team consists of the Nipigon District Family Health Team and our Nipigon Doctors Group. The Nipigon Doctors Group is our associated physician or affiliated physicians group for the family health team. So if we go to the next slide, you'll see a breakdown of kind of how we function. More on a funding level is sort of where we see the distinction here on this slide. And the funding does play a role in how well organizations can come together and work together as one. So we are a bit unique in that we have a Rural and Northern Physicians Group Agreement. So RNPGA is that acronym that gets thrown around a lot. And so if you're not familiar with northern, smaller rural communities, you may have never heard of an RNPGA. So our physicians function under that agreement. And then the family health team is funded the same way that every family health team across Ontario is, which is the Ontario Health Agreement with the family health teams. So we have limitations from a family health team side, how funds can be used in relation to your affiliated physician group. So you have to get creative in how you're going to work together on that side of things. One thing that we're really fortunate for right now is that we have no vacancies. So we're funded for 5.5 full-time physicians. All positions are filled right now. All of the doctors' groups, other support staff are filled. So they've got a clinic manager, 3 receptionists. On the family health team side, as you can see the list, we're a team of 10 people, and we also have no vacancies right now. And actually, we just passed our 2-year mark of no vacancies. So we are really excited. So I joined this team 2.5 years ago as the executive director. And it came at a time where there wasn't a lot of work going on between the two organizations. There was a lot of mistrust going on between, and communication had really broken down. So I didn't walk into a very well-functioning primary care team. I walked onto the family health team as the executive director and then had to work to also build the trust with the doctors group. So we'll go to that next slide, please. So it was really interesting being asked to do this presentation because I had to sit back and think, well, what do I do here? Because in a day-to-day, you just there's just a lot that goes on when you're the only manager of a team. And so I kind of had to reflect and kind of, it was interesting hearing, I think it was Mike or somebody was talking about the evidence behind leadership in teams. And a lot of my presentation falls in line with that evidence. So I thought it was just basic common sense stuff because it's my day-to-day, but actually there's evidence to back what we're doing here. So, I mean, relationship building is absolutely at the core of what we need to do in order for both organizations to come together. And again, I had to build trust. I had to build trust with my own team. I had to build trust with the physicians group. And, ways to do that are, I like that term, courageous conversations. One of my first meetings with our physician groups, I had to say, what's working well, what's not working well, what would you like to see different? And, had to just listen. And you have a lot of different personalities at the table, both on your family health team side and your physician group side. And there can be strong opinions, there can be resistance to change. So you do have to start to get to know the different individuals and how they function and how they think. And then, through time, that trust gets built. And then there's more honest, open conversations that can happen. And then we can start working towards improving change. And so that's kind of where we're at now. A big learning as a leader is you can't take things personal because there's a lot going on. And if you just take every negative thing you hear on yourself, you're not going to last. And then, as silly as it sounds, with regular meetings, you need to have set dates, set times, and you have to stick to them because it's very easy. I like to joke that we're sort of trying to fix a train going down the tracks at high speed while also, driving the train. So, things get overlooked quickly if you don't stay on top of things. So that's where I really do find it helpful. If you're having a meeting, have minutes because we need to have a record of, what was the plan, have an action item list, go back to it, who's accountable for what. So accountability is huge when you want to see progress. But also, in assigning that accountability, it's important to have it where people are stepping up to the plate and wanting to take on that accountability. If, you're constantly dictating or delegating that accountability, you're not going to have as much buy-in. So trying to have those opportunities where people can express their wishes and their passions and then trying to, direct them on how can they do some work towards those things. And then I also find, feedback is huge. If any of you, are familiar with McMaster and their problem-based learning, that's where I did my master's. And it was all about feedback in our small groups. And I hated it, but man, has it paid off over the years. So to be able to give not only positive feedback, but constructive feedback, and also to receive it too. So it goes both ways. And you need to, just be able to give and receive feedback. And then making sure your staff do get the education that they need to not feel underprepared or overwhelmed by, whether it's a new task, a new program. And I'll talk about it in a bit later when it ties into like getting people working to their full scope of practice. How do we do that? And then another big part of how we've kind of come together better over the past 2.5 years is we've had a few non-work setting events. And it's always, at staff expense. And so we've done murder mystery events. We've done a best ball golf event, coffee and conversations we'll host. And it's just really good to take people out of their stressful day-to-day work and allow them to be, together in a more relaxed setting and sometimes a funny setting. And that'll get people to open up more to each other. And that also helps with that relationship building. So go to the next slide, please. So communication strategies for shared care. So like when you have, all your different IHP staff and your primary care provider staff, all working towards that common goal of, what does our patient need? In order for that care to be efficiently done and not have big time lags, we really need good communication. So a reliable IT infrastructure is so important. And I feel like in this day and age, it's like, oh, shouldn't that be obvious? I walked into a family health team that was so behind the times for IT and technology. And so sometimes you do have to do those investments in making sure that you have reliable infrastructure because if you're going to ask everybody to rely on an EMR and that EMR keeps crashing or the VPN doesn't work from home consistently. So, there's frustrations that build up and then it's not efficient for people's time. And that becomes, another source of frustration as well. So reliable IT is very important. And of course, your team, you should all be on one EMR. And I think most family health teams and their affiliated physician groups will do that. It's especially important for those messages that go back and forth. So, for example, we have, our diabetes education program, and when one of our CDE staff need the physician involvement for that patient, they can easily send a message. It's tied into that patient record, and there's a tracking of it all. So it's just a really nice feature that an EMR preferably would have. And then our VPN is very important for us because a lot of our physicians, they don't live here, and so they might work their days and then be gone, but they still like to, continue to do their care. So the VPN allows for that continuity of care. They can go right into the EMR from home, from Spain. We have somebody this week in Spain, and he's checking his messages. Excuse me, I'm getting over a cold. And the family health team also does a lot of community outreach. And so we've been able to still go onto patient EMRs. I'm going to take a water break. Sorry. So we can go onto the EMR while we're in the community, and then we can, oh my goodness, this was my fear this morning when I woke up with this cold. So it allows us to, we can order labs for that patient right from the community clinic. We can send off that rec for the mammogram that patient keeps forgetting to pick up the phone and just do the self-referral. We can send that off for them. And we can do it all right there out in the community. We don't have to have them come back into the clinic. So the VPN is a very useful tool for us. And then co-location, I mean, ideally, you would love to have everybody all under one roof, all working together, but it doesn't always happen. Co-location does allow for more of those informal, in-person conversations to happen, so your team has more of a connection, but you can still have that ongoing when it's virtual as well. And so again, all goes back to that reliable IT infrastructure. If you're going to ask people to try to be virtual and be present, then we need to make sure we have good IT for that. Yeah. Education is sorry, I jumped over there. Yeah, sorry, ready for the next slide. Okay, so when we come to co-designing programs, for me, that the base starting point would be an evidence-based guideline, because obviously we're all here to get the best care we can to our patients, and so your evidence-based guidelines that are out there are a great starting point. And then you look at what can we do with our resources here, and we build out from there. And, a way to try to make sure everybody's voice is at the table is, if I have a staff member, for example, who's passionate about hypertension management and we needed to revamp that program. So that person took it on to start working on a procedure and start working on what would that program look like. And then through guidance with myself, back and forth, we kind of work on a document, share it with the other staff that'll be involved, and also share it with the physician group, and also have them attend meetings with the physician group so that we can all have our opinions about what does or doesn't work. But then it's important to have follow-up after as well to say, okay, we've been trying this for 6 months. What are we doing now? So that's where the co-designing and having the ability to have good conversations with your team is very important. And so when we create our programs or improve our programs, we're trying to use our family health team staff to their full scope of practice if possible. And part of that is we give them training, whether it's internal or from an outside source. So for example, I have a nurse who is, having some challenges with some sutures. And so one of our physicians had said, you know what, I wouldn't mind, I'll hold a lunch and learn for your nursing staff to come and learn more about sutures. So just a lovely way for, them to work together and get some education and affecting that or helping that need that was identified. And then we look at medical directives that would be tied directly to that program procedure. So, it's going to help with that continuity of care. So in our diabetes program, if the CDE recognizes that person's lab work for their diabetes is out of date, they can, through the medical directive, order the lab work. If, it's caught that in their Prev care, they haven't had their mammogram in the time period needed, they can organize that for the patient. So we have those medical directives built into our different programs so that it can move things along much quicker than always having to send that patient back to their primary care provider to then do those referrals. And then we also have different custom forms within our EMR, which will allow for, easier reviewing of notes. And then more consistent documentation as well. So, we've edited and revamped different custom forms in order to make sure that both sides who are using the form get what they need out of the appointment and they have that information. So we'll go to the next slide. So just to kind of wrap up, so medical directives, they really do help with getting staff working to their full scope, and also making sure that they tie into how it's going to support the program and support the patients to be able to get the timely care. And I did allude to our hypertension program. So we didn't have a formal program when I came here 2.5 years ago, and it was really causing a lot of friction between staff, like who was supposed to do what and the different expectations. And so we created a formal program, assignment of roles, reviewed by your PCPs and your allied health. So it was sort of everybody's voice was there. And now we're reviewing it again because we've been at it for almost a year. And so it's like, okay, well, what is working? What isn't working? And now how do we change it to make sure? And then the other piece to think about is professional development and trying to make sure that you do budget for that because it's really important. I actually, just for fun, did a survey with my staff before this, and it really does aid in avoiding burnout and also just retention, because a lot of my staff have identified if I didn't support them in their different passions for work and improving their skill set, they might look for work elsewhere, and that wasn't said in like a unkind way. It's just really did help with retention. Yeah. And the last slide. So there we are at our murder mystery. It was a 1920s party. And, you know, I like to say, like, nothing gets people out of their comfort zone, like dressing up and having to act like a character from the 1920s. So that was an epic night, and it was really a bit of a turning point for our teams to just start working together. So thank you for listening, and happy to answer questions.
Great. Thanks so much, Melissa. We'll come back to questions after Mary Jane is presented. But thank you. You get lots to think about, and there's questions coming up in the chat, which I'll refer to when we get to the discussion. Our next presenter is Mary Jane Rogers. She's the Executive Director of the Aurora Newmarket Family Health Team. I believe she's going to share her own slides, and so we'll wait for that transition to happen. Again, keep typing your questions in. I think the part of what we want to be doing is problem solving some of the issues, like the one that Nicole has brought up around what if you don't have a single EMR? What can you be doing that will create teamness across practices that may be collated or may not co-located or may not be co-located. So I think that's
and Mike, in future events, we will actually really talk about how to share resources across practices and across practice types. So you'll hear much more about that in the next RISE sessions, about examples right here in Ontario about how groups are sharing a whole variety of team resources across different types of practices in Ontario right now.
Yeah, great. Thanks, Rob. Go ahead, Mary Jane.
Hi, everyone. Thanks for having me. So I'm going to piggyback on some of the things that have already been said and tie it into how we work all together here at the Aurora Newmarket Family Health Team. So I just wanted to bring this slide up because it's really important that you see we were established in 2008 in the third wave with we were just discussing it this morning with I think it was 2,000 patients and 3 physicians and about 226,000 in budget, and we're just over $1 million now. So, and we've grown to this. And I'm going to talk about how this team collaborates and just things that help us function as a team, and it's happened over time. And again, this slide again is very important in when I talk about us. It's because it shows the way we it highlights our strengths. It highlights how we bring everybody together as a cross-functional team. So for example, even though you see the FO administrative team is funded by the FO physicians, I manage that, all sort of putting people where their best skills are. And I manage the day-to-day administrative, the HR, and the operations for all employees, all FO and FIT. Our lead physician manages all the clinical aspects, and the IHP group will go to her for clinical support and guidance. And that, again, is utilizing people's skill and what they're good at and what I'm here for at the team. My lead physician and I meet once a week. Sometimes it's for 15 minutes. It's a touch point. We discuss in real time what's going on. It ensures we're both kept into the loop. So if she's got a clinical issue she's dealing with, or I have an administrative, we share that. And sometimes we just use it to catch up and see what we're going to be doing down the road in the weeks and months. She's also a board member, and sometimes maybe even to brainstorm, get throw ideas at each other. And again, it's not a lot of time, 15, 20 minutes each week, and it's really beneficial. And I think it's really important because it shows the whole team that her and I are communicating, right, at that level. I wanted to share this also because this is what our Schedule A document, that anyone that's a FIT knows what that is. And from the ministry days now to Ontario Health is what we report quarterly. And I want to show it because it's not just physician-led. It's IHP. Physicians can refer in, IHPs can refer in, and patients can self-refer. And why I bring this up is to show kind of right care at the right time. So, for example, if our occupational therapist goes into a home or has an appointment with a patient and maybe suspects a mental health issue, she can then come back and round or refer to our social worker with a note through our EMR to the physician. So they are kept in the loop, but it's brought to the attention. There's no waiting, and that patient there could be no issue, but there could be an issue. So we allow that and have for years. And, we ensure that the physicians know about all of these programs. They're in our EMR. There's a list in our EMR that they can look at. It's posted in all the exam rooms. And it's really important that we advertise these programs in advance. It's not perfect because we struggle with attendance, and we're always working on how to get more patients involved, and not just our website, not just our socials, but like I said, it's posted in our waiting room. It's in each of the exam rooms, and the clinicians have a cheat sheet sort of thing that if they are seeing someone one-on-one, they can refer back. And I mentioned Schedule A. Schedule A and our quality improvement plan, our QIP, are two living documents that we have for as long as I've been here. They're intertwined. Our quality team approves both of those documents. We review it monthly and quarterly. Our board gets a final approval before it's submitted to Ontario Health, and all team members have access to those two documents. We walk the talk, we live it. That's what drives our not only quality improvement, but our kind of day-to-day planning for our patients. And I mention it because it's working. We're not working in silos. The FIT isn't offering these programs and the FO doesn't know about them. And it's really important that everything from cross training, which I'll talk about a little bit, and working across the FO and the FIT, we don't work in silos. And I'll get into that a little bit here. This is an example I just wanted to show everyone. This is our quality scorecard, and it goes out monthly to all team members, to all board members, to all admin team members. And it just at a glance, and we get into pretty detailed discussion. I think someone mentioned about usage of the IHPs. We have a more detailed quality scorecard that goes to our quality team and goes to our board of directors on a quarterly basis. But this is a snapshot so everybody can see what we're working at. And again, ties back into our QIP, ties back into our Schedule A. And it's important because then everybody knows where we are. Communication, you probably hear it over and over again, but without it, the team just doesn't work. We have an email that we go out on a Monday morning, and it's called "What's Going On?" Like that's exactly what it's called, and it's just a quick snapshot to everybody. Who's in the office, what's going on, who's away, if there's a program running that week, and it takes 30 seconds to open the email, and we can also track who's looking at it to see if it's effective. And then around this slide, I've mentioned things. I've listed our meetings and interactions that go on. And sometimes these meetings can go 45 minutes, and sometimes they can go 15 minutes, but they happen consistently. We don't not have them. And if half the team's on vacation, we still have that meeting, because what we do is we do an agenda. We have a standing agenda for every one of these meetings. We have a parking lot so that we don't forget something, especially with our monthly team meetings. If we put something in a parking lot, that's followed up at the next meeting. Or if it needs to be followed up before, it's brought into the daily huddle. I don't set the agendas. Jessica does a call out and for each meeting that people can put whatever they forward what they want on that agenda. I don't dictate these meetings, but I do add topics from an HR standpoint, from an operational standpoint, but and all of our clinical clinicians attend the monthly team meetings because they really support me. I've got a really good group of faux clinicians that support what we do here and, within the fit and the faux. At the team meetings, we order pizza once a month. I budget for that. And everybody gets after the team. And sometimes the meetings wrap up in 15, 20 minutes. Sometimes they're 30, 40 minutes. We stick to the agenda. We do icebreakers at the beginning. I like to just, throw out questions. Like one example last meeting was, what did you want to be as a child growing up? And we went around the table, around the room. And then at the end of every single meeting, we do around the room and everybody gets a kind of final say. And I think that's really important. And at the end of the meeting, and when they're done, everybody gets an extension of their own time, that admin time to get caught up. We lock the doors. We make sure on meeting days that patients are out in time, that kind of stuff. How we're integrated. And I think integration is huge and so important because it's how we work together across roles. And I know that was mentioned before, but clinicians, and not just physicians, I call them clinicians, they consult across with each other regularly. They have shared admin support, which really helps with the consistency and flow. And I just want to elaborate on the admin support. Everyone has a contract with the Aurora Newmarket Family Health Team. Their roles are spelled out in job descriptions. No, everyone is salaried. Nobody is hourly. We don't have a time clock. Everyone is treated like the adults they should. They know they have to be here. And, I don't have a high rate of employees missing time. Because they know if there's something happening at home or something's up, you just make a text message into one of the admins and we cover each other. And that's what I mean by talking about the administrative support. We have the FO pays funds for administrative staff supporting 5 physicians. And some people may think that's a lot, but it's not. The admins rotate through their work with each physician throughout the course of a year. So they're not working for one physician all year and getting used to that. And they support each other. They all have a backup for each other if they're on vacation or if they're sick. It's really beneficial. They know how to work with each of the clinic, and I say physician, I mean clinician. It allows for built-in backup support, like I said. And each of the admins are cross-trained and they do multiple roles. So they're not on reception all day. They do navigation, they do reception, they do phones, they're direct admin support for whoever the assigned clinician they're supporting. They do scanning. We do have an evening person, but they do throughout the day. Each admin has kind of a special area. So one will support IHPs from the FIT. One of them manages the dashboard for our EMR. One will assist with program attendance. And the FIT administrators are cross-trained into those roles too. They help, they do billing, they do IT, they do operational needs. And so what my point is, yeah, you're funded for this FIT role, but if that cross-training happens, things get done. And they get done in a good time. It's really beneficial that everybody knows what each other is doing, and it allows for backup support. So we don't go in if someone calls into sick to the office. We don't go into panic mode. People just know where to sit in and how to work. And I don't tell them what to do. They work it out themselves. It's such a well-oiled machine out in the front reception and administrative area that they know what to pick up. And it covers, there's coverage, there's collaboration. My clinicians rotate Fridays, Saturdays, and weeknight coverage, and the lead physician manages that. That's not left up to me, and they're really good at supporting each other through vacations and that kind of stuff. And she does it a year out so that there is opportunity to change. We have shared expenses for external IT support, and the FIT employees manage the EMR and any in-house issues that arise. But everyone is cross-trained on how to set up an OTN call, or how to fix a scanner, or how to fix a printer. It's not that they're waiting to wait for someone to come in and fix it for them. And we pay a little better than standard. And it took me years to get the full physicians, not years, but it took some convincing. If we pay them at a higher rate, they're going to come to work. They're going to be able to take on challenges. Pay them for what they really are worth. We operate as one entity with a few exceptions. We are the Aurora Newmarket Family Health Team. But we kind of say we have two divisions. We have the FO and we have the FIT. Cross-training works for supporting each other, and work is distributed fairly. I believe it works for us because we are a small team. We're under one roof. But I think the original way of thinking of how a FIT and a FO used to or should have operated when we started with the ministry, I think that's not what reality is now. And I think that's why it works under our roof. We've looked at making improvements, getting the right people involved, early in the beginning. If someone comes to me, I have an open door policy. If someone comes to me and, says we have a problem, my first question is, what's the solution? Let's work this through. I also think that I know how to do reception. And if we're short, I go out and help at reception. And I don't do navigating, if I can see the phone lines lit up, I'll jump on and take a couple of calls. I know how to book an appointment. If the toilet is plugged, I'll get the plunger. I'll sweep the floor, and everybody sees that. And I think it's really important that if people see that everyone's doing it, and it's, the bad word, not my job. If they see that, I really think the support is there for each other, not only for me, but for each other. We make sure that everyone's listening and decisions are not being made in isolation. And that's helped to make sure that the changes we're making are realistic and, they work in practice. It also helps with buy-in. And I mentioned the QIP and the Schedule A before. We live those documents. We all know that the patient is always at the center of the team. They're involved in their own healthcare, but we also don't allow patients to, I don't want to say don't allow, we don't, just because a patient is curt or rude on the phone. My expectation is that my team member who's talking to that person isn't going to be that way. And it's really hard. Human nature is to bite back, right? And we have done a lot of training here for that kind of thing, stress in the workplace, and how to manage difficult people. And we have directives, we have all of that, and everybody knows kind of what their role is. Our team has always been in the office for the last few years. We do virtual care, we monitor virtual care, but my whole team is in the office every day. We have the luxury of having the space, and the patient decides whether it's in person or virtual. And most of our clinicians want to see our patients in person now. But we also cater to those that maybe are working and need a 15-minute call with the clinician, and they do that also. Advanced access is something that we took on about 10 years ago, and that's kind of the third next available. It's timely access, and we monitor it. It's really important that a person gets in at the time of their choosing. We have a very colorful EMR where whoever's booking those appointments knows when to book. They know what questions to ask for urgent care, and it works. It really works. We're always talking about it. Every month at the team meeting, we're talking about it. But our rate, we have about a 3-minute hold average on our phones, and our patients are getting in. When we do surveys, they're getting in to see they may not see their clinician every time, but they're getting in to see the care.
Mary Jane, I hate to interrupt, but can I give you about a minute or so to wrap up?
Yep. So
Thank you.
we do online booking. We do like I said, the weekly, the daily, the monthly meetings, and our programs and services are offered. I think trust is the most important thing. Knowing each other's person's contribution, allowing others their limitations. It's not easy. It's not easy at all. But I think understanding each other's personalities, and we do all kinds of things like team culture. We socialize. We do contests. We make sure there's safety in place. We do a reality check. It's not perfect, but they sometimes maybe think their ideas aren't being implemented, but we give them feedback. I think it's the most important thing too. We allow others to recognize each other. I think I borrowed it from another team. We call them dazzlers. So if somebody's done something good, another team member can give them a dazzler, and every 6 months we count out who has the most dazzlers, and they get a gift card or a gift basket of that kind of thing. I know it's not something that we hear a lot, or maybe we have been hearing it, but kindness is my favorite word. I think that we need to support each other, and we have to allow each other the freedom to talk and to speak and to respect each other in communications. I think it's really, really important. And my mom always used to say to me, if you can be anything, be kind.
Wonderful. What a wonderful note to end on, Mary Jane. Thank you. Thank you, Melissa and Mary Jane. I'll just quickly, sort of summarize what I heard, and Rob and Dean, please jump in, or anyone else for that matter. I think what I heard consistently through both conversations is that this is about relationship building. That it's not only just about trust, but it's about trying to be friends and colleagues in the work. We talk about marriages need to be worked at in order for them to continue to function. That's what I heard about these teams, that in order to build that trust, you need to be kind. That really stuck with me, Mary Jane. But you also need to have fun as a team. So I think that's the first step. And a good leader will make sure that the work environment can be as fun as possible and reduce stress as much as possible. We've talked in the past about having people work to scope of practice. We've talked about medical directives. We've talked about clear protocols, roles and responsibilities. And those are all structural things that need to happen in a high functioning practice. But I think even before you get to those, you've got to have that trust, that relationship, and people that enjoy working together. Robert, Dean, do you want to add to that?
Yeah, Mike, agreeing with you here. And I just wanted to congratulate Melissa and Mary Jane. Really, really congratulate you. This is really hard work. And all of the stuff I gave about the evidence about building teams, you put it into practice in real ways, in significant ways. You covered the gamut, and just congratulations on that work. It's just been fabulous. Another couple things I heard was really the importance of communication channels for those team members and living the talk, making sure that everybody knows what their roles are and really defining those roles, but yet coming in and helping other people with their roles when they need to. Mary Jane's examples of, she will get in and answer the phone calls if they're needed is exactly how teams operate. So just a few real nuggets about teamness, role clarity, and then really it's about a long-term prospects. Teams are not built overnight. It's a development process, and Mary Jane and Melissa have really shown us that. Thank you.
So it's time for us to talk about group discussion and questions. Nicole, is your question still one that you would like to talk about? Your original question about being in a foe? And would you prefer that I ask the question? Doesn't sound like she's there, so I'm going to read the question. As a faux physician who left a team-based model, 15 years at a CHC and a PCN lead, oh, there she is.
Sorry. I just went downstairs to get myself a Perrier, getting ready for the game.
Okay.
I literally took the day off today to watch the game. So,
okay.
But anyway,
I'm just raising your question about being in a phone. Is after listening to all of this, is that still a question you would like to address?
So yes, I mean, I find these webinars, so inspiring to hear about how organizations have developed strategies to overcome the challenge of teaming and teamwork. Certainly, as medical director of a CHC, trying to build a team and trying to make the team functions, I did a lot of work on all of this stuff and recognizing that how challenging it is to really create a team even within an organization. Now I'm in a situation where I'm practicing in a FO and I'm lead of a primary care network and trying to develop ways for independent practices to have access to allied health and other team resources. But this is, so we're kind of mashing up the models as we sort of talk about through the PCAT funding and initiatives. But really, I feel like there's no support and strategy on how to come together when you have one organization who hires a nurse that goes and works for an independent practice to help them build capacity so they can take on new patients. That's one example. You've got a CHC, like the SPIN model, where you have a centralized intake for independent practices to access CHC resources. Okay, well, how do we build that in such a way where we are learning from each other and we are teaming well, as opposed to it being, well, that's their resource and we access it, from time to time, right? That it's more of this team building, because I really think that, that's where some of the hard work is, particularly in urban areas like Toronto, where it's not so much about lack of resources. I mean, there's always that. It's really more around how we're using them and how we're working together. And current state is that there's a lot of, like, people are disparate, right? People are heads down, working, seeing their patients, not really connecting with the system at large. So I would love to hear more about how we can be overcoming the organizational silos that can, and in more, it's not always, but in some areas, these organizational silos that prevent good teaming. And how do we define teaming at a cross-organizational and even cross-sectoral process?
Okay, who wants to tackle that one?
I can give one example. And what we do is, it's part of our quality. Sorry, there we go. What we do from a team standpoint and sharing of resources. So we track, percentage wise, how much each of the clinicians use the OT, use the social worker, and we share that with them, and they can see, especially when it comes down to the big one is the nurse practitioner and who's utilizing her more. And in the beginning, when I started years ago, it wasn't fair. So what we did is we took our EMR and we've designated to make it fair across the board how many appointments, and we're small, so we can do it. It's much more difficult with big teams, but we identified how each of the nurse practitioners' day is spent, seeing so many acute for each doctor, so many of this, so many of that. And we do the same for the social worker and the OT, and our nurses not so much, but the those specialties, so that it's fair across the board.
So exactly. And how do we convince the CHC who, wants to be providing services to be collecting that data and then making the time to share it with the users and the PCNs? Like yes. And how can we ensure that this is the sort of thing that's happening as we are trying to, break apart the silos and build with co-design, right? And I think that's where some of our challenges are, because we say, hey, yeah, let's do this together. And then it's dropped, right? Or it's not part of their current work plan or their current what their current board says that they want to be doing. So I find that that's like, as someone trying to rally this kind of collaboration, it's it's very much down to the organization and how willing they are to be collecting and sharing this data. Like, that sounds great where you are. And if we could, do you see what I mean? Like, it's just, perhaps I'm being cynical, but it's been a slog. It's been a real slog to try and like make this work.
Yeah. I will comment on an organization that I worked in, that both Rob and Dean also worked in the US. What we found is that you could give primary care teams all the tools they needed to be high functioning. You could ask them to collect data, you ask them to do quality improvement. Some picked it up, many didn't. It wasn't until leadership actually gets involved. And if our leaders aren't saying this is what you need to do, then there's very little impetus for people to try doing something different, especially if they're slammed with 35 visits a day or whatever the case may be. So, I think on some level there needs to be agreement across maybe PCN leadership and OHT leadership that this is the work we need to be doing, that we've got our TPA agreements, yes, that's true, but ultimately you're going to be dealing with building patient-centered medical homes. I mean, that's really where we're heading with a lot of this work. And so I think the more we talk about that vision going forward, the easier it is for teams to get on board with it. There's also the old adage of people do what you pay them to do, but we can't necessarily pay for everything, but we should look more closely at how we do pay people to do this sort of team building work, because I think you'll see more of it. I don't know, Dean, what are your reflections on?
And yes, I definitely can see challenges, and again, especially in all the different compensation models that exist. I guess I would sort of say one of the first things in leadership gave us the vision and values, but then the team members sat down and we also sort of went through it ourselves and really kind of, as you described, the tight and loose work, that was the tight work was what we were given. We then did the loose work, and it's like, hey, that's the bare minimum. We want even more than this. I think if you sort of look at that, with all the different people, what their values are, you'll sort of start to find the commonalities, and then you can kind of then go back to the, because it's getting back to the brass tacks. It's like, how is this costed? How will it be paid for? But if you have the value set, you have the team who can then sort of figure it out much more agreeably. I guess to use the hockey analogy, it's somebody on the third line needs to come up to the first line. They still need to fit in their role, even though it's sort of a different one for them. And again, is how do you get them to play well with others?
Yeah, I think you described Renata fast, but that's okay.
Yes. Yes.
So, Nicole,
Melissa.
one thought that comes to mind when you said, how do you hold these different organizations accountable when they say they're going to do things? Well, that should be built into your MOUs. And I just wonder if, bringing people In
MOU?
person? Oh, like a memorandum of understanding?
I know what it is. I'm just saying these are not consistently applied across
Yeah.
OHTs and PCNs, right? Like this is
Okay.
yeah.
So like one thing I find really great in our OHT is they bring us together quite frequently in person. And those in-person meetings generate a lot of great connections, a lot of great discussions. And so, if you have these different organizations that are now meant to be working more as a team, maybe to create the MOUs, it is done as like an in-person session so that both parties are at the table. Everybody kind of has an understanding of what they walked away from. Hopefully they felt heard, and hopefully they feel like, okay, I can live up to what I've committed to in this agreement. But yeah, if it's not written down on paper, yeah, that's a struggle.
Yeah, it's interesting that you mentioned that, Melissa, because for years I used to run learning collaboratives based on the Institute for Healthcare Improvement Breakthrough Series methodology. And so we would bring teams together from around the country or from within one organization and have them work on a particular problem. Usually it was a disease in order to help them build chronic disease and prevention management systems. Aside from the work that they did around building the infrastructure needed in practice to address chronic disease, the teamness that happened in those collaboratives was probably far more impactful than anything else. The 20 or 30 primary care teams that were sitting around the room looked forward to getting together, whether it was in person or virtual, so that they could understand that first of all, they're all in the same boat, even though they feel they might not be, but also that they could work together and solve each other's problems. And I think going forward, that kind of approach across the OHTs and PCNs might be very helpful. If we can figure out a way to bring all of you together, those of you that have experience building teamness, those that are just starting, and those that are adrift, and then trying to figure out what to do. I think it's a great way for teams to share. But Leslie.
I was going to ask a question from one of our co-leads. Unfortunately, Breen had to leave, but I think it's very much related to this conversation that we're having. And she was just curious from everybody participating today and from Melissa and Mary Jane, just around, when you think about turning points or milestones, at what point did you as leaders, or do the leaders know sort of the team is ready to participate in these team building activities? So coming together, it sounds like with Nicole, like there's some work still happening to bring your leaders together. So be curious to know from others, sort of like, what was that milestone or that tipping point that helped indicate you knew that your team was ready to come together to work on this? And maybe there was a particular one thing, maybe it was multiple little things along the way.
Yeah, I don't know that they're ready till it's done. What I'm saying is they're like, oh, we have to do this, or we have to do this, or we have to book time off to do this, but then when you and you have to follow it through PDSA, right? You plan it, you study it, and you act, and sometimes it's more like that apprehension, even things like reviewing vision, mission, and values on an annual basis. Oh, I got to do this. But then when they kind of see the outcome, I think that's so I don't know that everybody is ready. The person that is involved in that type of program or service or whatever they're doing, they're ready to do it, but it's kind of leading by example, and not just me leading by example, but whoever's responsible for whatever change we're putting into place. And if they lead, you hear people saying, oh, I was really apprehensive about this, but once we worked it through and put it in place, it really does work. Does that make sense?
Mm-hmm. Yeah. Yeah, absolutely.
And I think as well, actually, all leaders kind of know within the organization who the early adopters are, who they can use to help bring everyone along. Again, the chain is only as strong as the weakest link, kind of thing. And identifying the strong chains, getting their buy-in early and support to help everyone else ease off.
Yeah, that's a great point, Dean. And we had to do that we had to do that in these learning collaboratives also. The teams that volunteered to be part of a learning collaborative and try to do work differently and improve chronic disease, whatever, were those early adopters. And they were very good messengers after the collaborative to go forward and spread it to the other folks who were sort of watching them saying, what's that weird thing they're doing with that group of people? So they were great messengers to carry the message forward to other teams. Other questions, comments for our presenters? Well, Leslie, why don't we wrap up? I know Nicole you're being very brave, missing the first 10 minutes of the game.
Yeah, it's on pause.
Oh, okay. Great. So why don't we wrap up, Leslie, and we'll give people back 5 or 10 minutes in their day.
Sounds good. So just very quick reminder about some of our supports here. So if this is your first time joining, we have these sessions every third Thursday of each month, but we have other supports as well. We have coaching. So if you need help one-on-one or within your meetings, we're happy to join you there. And we have a new thing called Deeper Dives that have been running for a few months. And right now we're focused on the process of attachment. And those occur on the first Wednesday at 11 Eastern every month. So please feel free to reach out to me or Mike if you're interested in any of those supports. And our next session, we're going to continue to talk about optimizing team-based care. And as Rob alluded to earlier, we are hoping to really focus on that conversation Nicole brought up earlier about how do you share resources across different primary care enrollment models, across the OHT, across the PCN. So really continue the conversation that we started today. So just a big thank you to Dean, Mary Jane, and Melissa for joining us today and for sharing their learnings. It was extremely helpful to hear them. We will be posting this. The insights are not lost in our OHT shared space. And please feel free to reach out to us in the meantime. And looking forward to seeing you all again next month too. Have a great afternoon and enjoy the hockey game.